This presentation on autism spectrum disorder is by Gena, Tasha Jones, and Madeline Rose. Autism spectrum disorder, abbreviated as ASD, is a neurodevelopmental disorder that typically emerges in early childhood and can be diagnosed as early as 2 years. Individuals with ASD might have impaired functioning in the areas of social interaction, communication, and emotional control and regulation. It is important to note that ASD is a spectrum and the range of functioning and ability is unique to each individual. Approximately 1 in 54 children are diagnosed with ASD, but the cause is unknown. Boys are 4 times as likely to be diagnosed than girls. In this presentation, we will explore the history, DSM-5 diagnostic criteria, a case example, evidence-based interventions, and more. In 1911, Eugene Bleuler created the term autism, which he thought to be a severe symptom of schizophrenia. He believed that autistic thinking was a way of avoiding reality and having internal thoughts that aren't readily accessible. In 1943, Leo Kanner argued that autistic disturbances were different from childhood schizophrenia. He believed that children with autistic disturbances were unable to relate to others and had language and sensory difficulties. In 1944, Hans Asperger created the term autistic psychopathy. Basically, he saw autistic thinking in higher functioning individuals and saw autism related to social difficulties. Autism was not mentioned as its own disorder in the first 2 editions of the DSM. Autistic thinking was used to describe a feature of schizophrenia like what was mentioned in the previous slides. The category of childhood schizophrenia was taken out of the DSM-3. A new category called Pervasive Developmental Disorders was created, and autistic features was removed as a symptom of schizophrenia. Pervasive developmental disorders included infantile autism, childhood onset developmental pervasive disorder, residual autism, and atypical form. The 3 features included impairments in communication, abnormal responses to environmental stimuli, and a lack of interest in social interactions, all occurring before 30 months of age. And the DSM-3R, the name was changed to autistic disorder and included a pervasive lack of responsiveness to others and removed the under 30-month requirement. In the DSM-4, under pervasive developmental disorders, there was autistic disorder, Asperger's disorder, which was marked by impaired social interactions, communication, and imagination, pervasive developmental disorder not specified, childhood disintegrative disorder, and Rett's disorder. The first bolded 3 were considered part of the autism spectrum. In the DSM-5, pervasive developmental disorders was replaced with autism spectrum disorder. A new category of DSM disorders emerged called neurodevelopmental disorders. ASD was placed in that category. Subtypes of ASD were replaced, making autism one large spectrum. ASD can be diagnosed as early as 2 years old, but signs and symptoms can be noticed earlier or later depending on severity. Those early signs and symptoms may lead parents to become concerned with their children's social interactions and how they are not meeting milestones. Pediatricians are also on the lookout for ASD during checkups and around this age. And if signs and symptoms are present or concerns were presented by parents, then appropriate assessments will be conducted accordingly. The earlier one is diagnosed, the better for early intervention. Criteria A consists of persistent deficits in social communication and social interaction across multiple contexts, essentially poor communication skills and interactions. The first point is social emotional reciprocity, which refers to neurotypical back and forth social interaction. An example of having a deficit in this area would be when you meet someone for the first time and dive into a whole conversation about yourself and not leaving room for them to speak, thus lacking the back and forth social interaction. Another example would be being unable to share feelings when something is bothering you, or being unable to respond to someone telling you that they are having a bad day, thus lacking that emotional reciprocity. The second point in deficits is nonverbal communicative behaviors used for social interaction. An example of this would include lack of eye contact, like completely avoiding it or even using it incorrectly. Another example would be lack of facial expressions or lack of control of them. This can stem from not understanding or being able to read social cues. So this could be smiling when you hear about someone's death. The third point is deficits in developing, maintaining, and understanding relationships. For example, lacking interest in peers and engaging with others on a personal or social level. All 3 points must be present in diagnosis, whether they present currently or historically. Criteria B includes behaviors, activities, or interests that are repetitive or restricted, as indicated by at least 2 of the following. The first point is babbling, motor movements, or use of objects that are repetitive. An example of this would be when a child lines up toys or when a child is constantly repeating after you or repeating lines of shows. The second point is excessive resistance to change in routine, distress to change, or ritualized use of behaviors. The third point is interests that are specific or unusual and manifest in fixation. The fourth point is responsivity to sensory inputs or engagement that is atypical. Examples of this would include sensitivity to light and loud sounds. Current severity is specified by communication impairment, repetitive behavior, and patterns, and these symptoms must be present in the early developmental period. Level 1 requires support. Individuals who do not receive support could have noticeable impairments in social communications, such as initiating social interactions or appropriate responses to social cues. These include repetitive or restrictive behaviors, such as problems with planning that hinder independence and difficulty switching between activities. Level 2 requires substantial support. Those that require substantial support for Level 2 severity include individuals with deficits in nonverbal and verbal communication, limited initiation in social interactions, and minimal response to social cues. These include repetitive or restrictive behaviors such as difficulty reacting to change, behavior that is inflexible, and distress from change. Level 3 severity requires very substantial support. Level 3 is essentially the same as Level 2, but includes greater and more severe reactions. For criteria C, again, signs and symptoms must be present in early development. For criteria D, symptoms must cause clinically significant impairment in social, occupational, or other important areas of current functioning. This means how much these symptoms affect daily living and functioning. For criteria E, symptoms cannot be better explained by another diagnosis or medical condition. For example, if a child does not make eye contact with you during a conversation, hearing loss or vision loss would have to be ruled out. Autism spectrum disorder versus attention deficit hyperactivity disorder, or ADHD. Children with ASD may exhibit behaviors like tantrums due to change in schedule or moving one of their toys out of line, while children with ADHD may exhibit behaviors due to impulsivity or hyperactivity. Number 2 is ASD versus language disorders and social pragmatic communication disorders. Although both are similar in regard to an impairment in social communication and social interactions, ASD also presents in restricted and repetitive behaviors or interests, along with abnormal nonverbal communication, while language disorders and social communication disorders do not include those. This case example was taken from the National Institute for Health and Clinical Excellence in the United Kingdom. Howard is 7 years old and presents at his GP with his mother as she is concerned about his challenging behavior in school. He is very non-compliant and has hit staff and pupils. Howard has early language delay but now uses fluent sentences. His school reports indicate that he has moderately impaired intellectual ability with above average reading skills and a marked failure to develop any peer relationships. His parents report that his language is stereotyped and repetitive and that he repeats videos and DVDs. He is very limited in terms of initiating social communication and has a restricted pattern of interest, currently an over-focus on DVDs. He has stereotyped repetitive motor mannerisms and seeks to feel people's clothes. Howard does not use eye gaze, facial expression, and gesture, but is an infrequent initiator of communication. Howard shows some appropriate responses to other people's emotions, but also often feels an odd response, for example, smiles if distress is shown. He is unconcerned about modulating behavior according to the social context and has some fixed routines, for example, reading through all the notices at the swimming pool every time. For evidence-based interventions, early assessment is significant to patients' progress in determining the best approach. Clients must be assessed by a trained professional such as a psychologist, psychiatrist, neurologist, or pediatrician, using observations, direct interaction, parent interviews, developmental history, evaluation of social history and interaction, communication, emotional, sensory, cognitive, and adaptive behaviors in multiple settings. The most effective treatment for a person with ASD is applied behavior analysis. It is used in both a school and clinical setting. It assists the child in learning positive behaviors. The form of treatment also focuses on decreasing negative behaviors. ABA stands for Applied, which its goal is to create a clear and rapid advantage to problems of social significance. The B is for Behavioral, uses measurement of behavior objective and accurate reflection. And the last A is for Analysis, employs a controlled method to understand what in the environment influences the person's behavior. ABA can be used to develop a wide variety of skills for the individual. A second type of treatment is developmental individual difference relationship-based approach. This is called floor time because the floor is with the child. This type of treatment is meant to provide intellectual growth and emotional support through teaching skills in a safe and caring environment through communication and emotions. Occupational therapy can be used to assist the client learning life skills such as bathing, feeding, dressing, and other skills. It is meant to teach them to be independent. These are some various evidence-based school treatments for ASD intervention. There's the antecedent package, which modifies a child's environment before a behavior occurs. Behavioral package, there's a review on what happened before and after the event, and it focuses on antecedents and consequences. Comprehensive behavioral treatment for young children is an intensive service based on ABA. It offers a 1-to-1 student ratio and combines many of the antecedent behavioral strategies. Pivotal response treatment learns the behavior skills in the environment. Joint attention intervention develops the skill of joint attention, and schedules are used for a need for predictability. Modeling shows the acceptable behavior. Naturalistic teaching strategies learns behavioral skills in the environments. Peer training package focuses on social and communication skills. Self-management places focus on deficits of adapting behavior as well as cues to the environment. Story-based intervention package uses stories for understanding. So there is no cure for ASD. There is no medication or drug to treat ASD. However, there are medicines that treat symptoms experienced by the individual, such as depression, trouble focusing, insomnia, or seizures. Evidence-based studies have found that medication is the most effective when it is combined with behavioral therapy such as ABA, DIR, and occupational therapy. As noted, there are several approaches to ABA and DIR that can be used to assist children in improving behavioral and skills. The treatment approach should be customized to the client during the assessment of what behaviors to be addressed and the treatment that will address these behaviors. The only FDA drug approved by the FDA for the individuals with ASD is Reciprocity. This drug is approved to be prescribed for children between 5 and 16 for irritability. Doctors may prescribe a selective serotonin reuptake inhibitor as an anti-anxiety medication or stimulant. However, this drug is not approved by the FDA for ASD. There is no recommended diet for individuals with ASD, yet diet is important. One thing to note is that children with ASD will typically restrict or eliminate things in their diet. In addition, parents might try gluten-free to see if it improves symptoms. There is no approved diet. However, children with ASD are known to have thinner bones than other kids. Therefore, the child should have bone-building foods. The parent or caregiver should work with a nutritionist to develop a healthy eating plan. And these last two slides are the references page.